Let me now talk about another case of controls, and that is organ donation, okay, which people don't usually think is an issue, an economic issue, but in fact, it most definitely is. And I have an actual diagram with figures that are accurate, at least for 1995, I believe. Yeah, 1995. Let me see if I can get this centered and then focused in on. Okay. In 1995, the demand for, now, by the way, in 1984, let me just backtrack a moment. In 1984, in the United States, the Transplant Act of 1984 was passed, and it makes it a felony to buy or sell organs. Okay? So, in effect, that means that there is a zero price. P equals 0. Now, for family reasons or for altruistic reasons, people sign donor cards. Okay? Most of the organs that are transplanted are cadaveric. They come from dead bodies. Okay? But there's a proportion of donations among family members. Okay? So in the case of kidneys, there were 10,000 kidneys donated in 95, and yet 40,000 people needed transplants, were on a waiting list. Okay? Regarding hearts, numbers were 2,400 and 6,400. Okay. What occurred, of course, was that some of those people between A and B, for both kidneys and hearts, died while they were on the waiting list. I have the numbers here. 731 of those waiting for heart transplants out of the 4,000 that didn't get them died. Okay, and for kidney transplants, out of the 30,000 patients on the waiting list, over 1,300 died. Okay, for lung and liver transplants, 290 and 674 patients died respectively while they were waiting for organs. Okay. Now, how did the government meet this crisis that had begun to develop since 1984? There was another reason why it began to develop, because in 1986, cyclosporine, a drug which was designed to inhibit organ and tissue rejection, was allowed onto the market. Okay, and there was also an increasing sophistication in tissue matching and in surgical techniques. So success rates for transplants dramatically increased. So you began to get a big increase in demand for transplants, but yet there was no change in there was no big increase in the supply curve, okay, or even in the quantity supplied. Okay. So this is simply a shortage caused by a price control of 0. It's interesting, and there's all ethical arguments. There's a number of ethical arguments against it. Why should an individual benefit from another individual's misfortune? Okay, let's say the equilibrium price is $75,000 for a kidney. Okay, so the attitude is, how dare someone accept $75,000 for a kidney? That's taking advantage or exploiting someone else's misfortune. Well, let me put it to you the following way. Do the surgeons that participate in the transplants, do they get paid? Yeah, they sure do. Hospitals get paid. Do the drug companies that supply cyclosporine and other drugs get paid? Yes. Everyone else that participates in the transplant surgery get paid. But no one raises any ethical questions about that. They're all getting paid as a result of this person's misfortune. In fact, anytime you go to a doctor, anytime you have any sort of surgical procedure, they're exploiting your misfortune. That's simply scarcity. Okay? There's a scarcity of good health in the world. Okay? So that ethical argument doesn't hold up praxeologically. Yes?
They've also had cases where kidney surgery at home, they take some of their tissue for experiments based on, like, if they have a special rare kind of cancer, and they don't inform the person, and they can make a lot of money from their research, but that person that's based
right.
on them would never get.
That's an interesting point Mila brings up. That is that in some places, if someone has a rare form of cancer, for example, or another rare disease, they'll take some of that person's tissue without informing the person of that, and use it for experimentation, and come up with new drugs and so on, and possibly a big money from successful research. Yes.
Because of the prolonged period of time that they actually put that person under to take that tissue, they put their immune system at risk, so that person does have a significant cost.
Right. So and that person isn't paid, and that person is put under for a longer period of time than he or she would be, and that impairs their immune system and puts them at more risk just to take this free tissue. Okay. So that's fine to do without if indeed that exists, not to inform people and to take a part of their body for even though it's not a vital organ for experimentation. But yet to pay someone who will donate the organ, who will sign will more people sign donor cards? Let's put it that way. What will happen to quantity supplied? Okay, if donor cards are permitted to be signed, or rather, if you can pay someone now to sign a donor card, which will then, which let's say embodies an agreement to turn over their organs to this organ bank after post-mortem, after they die. Okay, would more people do it at 10,000, 20,000? Of course, quantity supplied increases. Okay, as the price rises, and in fact, there's been surveys done. People's reluctance to designate themselves legally as organ donors can be attributed partly to procrastination, okay, I'll do it later, and partly to an anxiety harbored by some potential donors that, in the event of an accident, emergency room medical treatment might be less aggressive for accident victims whose driver's license are stamped organ donor, okay? In matters of one's own life, most people tend to be quite reluctant to take risks for free, okay? That's a fact of life. Would they overcome that reluctance at 50,000? Perhaps. More would, and more would overcome it at 75,000. Okay. So what you would get then is a greater number of people, the difference between QE, okay, and QS, able to get transplants. Okay, and you would have fewer deaths. Okay. The people that do not pay the higher price aren't necessarily people that can't afford to. They may be people who have a very short life expectancy, even with the donation, and don't want to go through the discomfort associated with that donation, okay? Or they might be people that just don't like surgery and would rather stay on dialysis. But the point is, like any other good on the market, it's not the rich people that get all of the good, okay? The rich people don't have all of the luxury cars. Some people will forego other things, some middle income people, or even lower income people will forego many other things because a luxury car ranks highly on their value scales, or their family will help them purchase it, and so on. Okay? Same thing is true with organs. Okay? You're going to have them distributed to those who value them highest vis-a-vis other goods and money on their value scales. Okay. There was one other point I wanted to make. Oh, predictably enough, a black market has, of course, grown up. And let me read you part of an article on this. They're talking about an individual. They say he was desperate for a kidney transplant, but getting a donated kidney, he was told, could take 10 years. That's when this individual's name is Moshe Tatey. He decided to pay a broker $145,000 to buy a kidney. Okay, and he said he was in terrible shape, and it didn't matter what it cost. He wanted to live like a human being, as he puts it here. In any case, there are now this is a later article. This is 2001 or 2002 here. There are nearly 49,000 people in the United States waiting for kidneys, so the waiting list has gone up. The only major organs that can be wholly harvested from a living person. More than 2,500 Americans died last year waiting for kidney transplants. So the number of deaths have gone up significantly, too, from 1,700. These numbers, along with desperate economic conditions in the third world, has given rise to a secret underground industry that is also fueling an explosive ethical debate. Yeah, the people that are debating it are involved in the ethical debate are people in academia, people whose organs aren't failing. Okay, they're the ones that are debating on whether this is right or not. Okay, within days of paying the $145,000, Tatey got a call from the broker late at night, telling him to come to Israel's Ben Gurion Airport. He and 3 other kidney patients were whisked onto a private plane, joined by a surgical team. They arrived in the Turkish city of Adana 2 hours later. The operations took place in a private hospital. The patients were brought in the back door. Tatey only glimpsed the man who sold him a kidney. He was an Iraqi soldier who had defected and needed money. Okay, so the market is operating. Okay, the market's getting around all these government regulations. I mean, they're sending surgical teams on airplanes and so on. Okay. Buying and selling organs is prohibited in almost every country, and yet it's happening almost everywhere. It says most of the people that are selling their kidneys are from poor countries. Okay. For example, in the former Soviet Republic of Moldova, one woman told ABC News she sold one of her kidneys for just $1,500. Okay. She did it to buy food for her children. Okay. And then they talk a little bit about the ethical debate. The idea that organs can be bought and sold used to appall Dr. Michael Friedlander, but then some of his patients started getting into the market. I'm seeing patients who were in dialysis treatment, says Friedlander. Some of them were in very bad condition, and suddenly 2 or 3 weeks later, coming back well transplanted, very happy, and a completely different state of health. So, these aren't just back alley operations where people are dying from them. The market is providing here, even though it's a black market, at least in many cases, a service that is successful. It says most physicians and medical ethicists say that buying and selling kidneys is wrong, period. Okay, what does that mean? Is wrong, period. Okay, I mean, they take into account the fact that not only the people getting the money are benefiting, okay, but also the people getting the organs are benefiting. Okay, that the woman that gets the 50. It's interesting. It's really the poor that are always the good ones, and the rich that are always the bad ones. So when a poor person sells an organ for $1,500, like this woman in Moldova, she's the exploited one. Okay, the one that's selling the kidney. All right. So it seems to me this is a physician talking. It seems to me a violation of the very nature of what medicine is about, explains Nancy Shepard-Hughes, to suggest that the poor should be allowed to dismantle themselves bit by bit with the help of the medical profession. They're hardly doing that. That's absurd. Okay, how is it any different from Alex donating a kidney to a relative? Okay, how's that different from a surgeon participating in that procedure from a surgeon participating in a procedure in which someone is selling the kidney? Okay. So I'm not even making an ethical judgment on it. What I'm saying is that praxeologically that they can't establish a difference between the two. Okay, they're both voluntary. They're both done in a way that improves the utility of both parties participating. Okay, both donor and recipient and buyer and seller both are better off. Okay, whatever these ethicists, bio or medical ethicists think.